In this episode of our podcast series on lung cancer screening in Canada, hosted by Impact Medicom's Sarah Doucette, we are joined by respirologist Dr. Stephen Lamb from the University of British Columbia and BC Cancer in Vancouver. Dr. Lamb is a distinguished scientist and Leon Judah Blackmore Chair in Lung Cancer Research at the BC Cancer Research Centre. His research interest is in early detection, chemoprevention, endoscopic diagnosis, and therapy of lung cancer. He was the recipient of the Friesen-Regal Award for Outstanding Canadian Academic Discovery and the Gustav Killian Medal by the World Association of Bronchology for his pioneering contributions to the field of early lung cancer diagnosis, the Distinguished Achievement Award from the University of British Columbia, and the Joseph Cullen Award for Lifetime Scientific Achievements in Lung Cancer Prevention Research by the International Association for the Study of Lung Cancer. We are also joined by general practitioner Dr. Rakesh Patel from Silverado Medical Clinic in Calgary, Alberta. Links and resources for existing lung cancer screening programs are provided in the podcast description. Hope you enjoy it.
So welcome, Dr. Lamb and Dr. Patel, and thanks so much for joining us virtually from Vancouver and Calgary. So in this episode, we will be talking about lung cancer screening in Western Canada. And I wanted to start off by asking, in your opinion, what are the greatest unmet needs for patients with lung cancer? And I guess we'll go to you, Dr. Lamb, first.
The greatest unmet need is to detect and treat lung cancer early to improve the outcome of patients with lung cancer. So currently, only 20% of lung cancer patients survive 5 years or more. So we need to improve on that.
And so unsurprisingly, you brought up the need for early detection of lung cancer. But what makes early detection of lung cancer so important? And what is needed to improve the proportion of patients who are diagnosed at an early stage of disease?
So early detection is extremely important. So when patients seek medical attention because of symptoms, the majority, roughly about 3/4 of them, already have advanced stage 3 or 4 lung cancer. Most of them are not curable. So that's why we have to detect the cancer early so that we can treat them more effectively.
And so what sort of programs are needed to improve the proportion of patients who are diagnosed at an early stage?
So we do need to have an organized screening program, very similar to screening mammography or colorectal screening, so we can structure the screening pathway properly. Because lung cancer screening is not just a test involving a CT scan. It involves a kind of a pathway from how to identify people at risk for lung cancer, how do we recruit them, and we need to address issues like equity, and then how to navigate the patients through the CT screening. And when there's a normal finding of the CT scan, we have to kind of help them to get a diagnosis early. And then when cancer is confirmed, they will be treated appropriately.
And so we know that screening and early detection can improve mortality rates in lung cancer. But how do you determine which patients should be screened?
So in contrast to other cancer screening programs, lung cancer screening is only for those at high risk so that the benefits of screening will outweigh the potential harms. We can define lung cancer risk in two different ways. One way is to use what we call a risk factor approach, such as using age and smoking history. People commonly use PEG years and the duration for smoking cessation if they have stopped smoking. So an example of that is the U.S. Preventive Services Task Force criteria and the Canadian Task Force of Preventive Healthcare criteria. But I think a better way is to use a risk prediction model using additional variables such as non-smoking and more detailed smoking history. So besides smoking history, we can use things like race or ethnicity, educational level, which is a reflection of the socio-economic status, a family history of lung cancer, history of COPD, the body mass index, to derive a risk index. So one of the best tests risk prediction model is a PLCO 2012 model that was developed by Dr. Martin Tamamagi at Brock University in Ontario. And this model has been validated in multiple countries around the world, and it's been shown to have better sensitivity and positive predictive value. We can detect more lung cancers in fewer people and can avert more lung cancer deaths. Then the number of people needed to screen is much smaller than using age and pack years criteria. We can also address the disparity from race or ethnicity, gender differences, and socioeconomic differences. And finally, it is also more cost-effective. So this is the reason why in Canada and also in the UK and Australia, we are using a risk prediction model to identify people with sufficient risk for lung cancer screening.
So once a patient has been identified at an earlier stage of disease, what kind of treatment options are available to them then with those early stage? And how does that impact the survival outcomes?
So for patients with early lung cancer, surgery offers the best chance of cure. Stereotactic body radiation is an option for patients who cannot have surgery, for example, because of poor lung function reserve or because synchronous lung cancers in different lobes of the lung. But for patients with advanced lung cancer, in addition to chemotherapy, we now have many new targeted drugs and immunotherapy that can control symptoms and significantly prolong the patient's survival. And some of these actually survive a long time. So I think we're definitely making advances in our treatment for lung cancer.
Are there any newer treatment options then?
The newer treatment are mainly for advanced lung cancer, where we have the targeted drugs and also the immunotherapy agents. Sometimes we can also combine immunotherapy with chemotherapy, so there are many options available for patients with advanced cancer. They also study ongoing to even looking at early stage lung cancer to combine surgery with immunotherapy. So those are promising results as well.
What pilot studies have been done in Western Canada that were the basis for provincial screening programs, and what initiatives are ongoing to address this need?
So over the last decade or so, we have done two studies. The first one is the Pan-Canadian Lung Cancer Screening Study involving 8 centers across Canada from coast to coast. So this is the first study where we test a risk prediction model to recruit or to identify people at high risk for lung cancer for screening. What we have shown in this study that we can identify a relatively high number of individuals who develop lung cancer compared to age and pack years alone that are used by the US Task Force and the Canadian Task Force of Preventive Healthcare. And more importantly, we have shown that the screening can identify people with early lung cancer. So about 66% of the lung cancer that we find by screening are stage 1 lung cancer, that they are potentially curable by surgery. So more recently, the international lung screening trial where Vancouver is part of the principal investigator in this international trial, we have shown that we are doing a head-and-head comparison between age and pack years criteria used by the US Task Force versus the PLCO risk prediction model. We have found that the risk prediction model is significantly more sensitive than the age and pack years criteria. So this formed the basis for us to use a risk prediction model to identify people at high risk for lung cancer who would benefit from screening. So another major thing that we have done in Canada, because of the Pan-Canadian study, we have a large bank of CT images. So we have derived what we call a lung nodule malignancy risk calculator. So by looking at the CT scan, if someone have a nodule, we can determine or estimate the potential risk of lung cancer. And this helps us to devise our strategy, how to follow the patient. Whether to just a routine recall in 1 or 2 years, whether they should have an early recall CT scan in about 3 months, or have an immediate diagnostic workup referral. So the important thing of this model is about 2/3 of the people taking part in the screening program can be triaged to a biannual screening interval type of strategy. So that saves a lot of resources in terms of how many CT scan we need to do for the person over his or her lifetime, and also reduce significantly the radiation dose. So this is a strategy we're going to use in British Columbia as well.
So to look at the roles GPs play in screening, what do you see as their role for identifying patients? Dr. Patel, you want to address this?
Sure. So again, with some of that information Dr. Lam provided, that's fascinating as well. And I guess from our perspective on primary care, when it comes to maybe looking at GPs and how they may be able to assist in lung cancer screening, I think the role really here, the GP strength is really prevention. That's really where we work. And actually, we would rather not get any of our patients to see Dr. Lam at all, not because there's anything wrong, but rather we'd like to prevent lung cancer as best as we can. And then, of course, exactly as Dr. Lam said, early detection is where primary care can also assist with that. And then finally, advances in treatment, much more within the realm of secondary care.
And how does a GP then refer a patient to the program?
So that's a great question, Sarah. And actually, that highlights some of the, should we say, the inadequacies or disparities across Canada in terms of lung cancer screening. So BC, we've just heard from Dr. Lam, have a fantastic program where they're working with this lung cancer screening program. Alberta, at present, do not have an approved lung cancer screening program. So this procedure of 3 low-dose CTs, for example, as an example, is not endorsed at policy level within Alberta. That's a bigger argument and a bigger discussion. But clearly, I think raising the awareness as to the value of this is probably something that at least will start momentum of change. But in terms of how a GP would refer someone, First, the screening program needs to be endorsed. And of course, with any screening program, that needs to go through the cost-benefit analysis and the criteria for the patients. Once that's an approved program, then we need to understand and educate family physicians and patients as to why they want to be involved, the value of screening, and also the potential harms associated with screening as well.
And how about in BC? Would you be able to comment, Dr. Lam?
Yeah, so the family physician plays a central role in a screening program. Patients see their family doctor as their trusted physician. They can ask information and whether they want to decide to take part in screening or not. So a patient can be referred by their family doctor to the screening program, or like mammography, they can also self-refer. But in British Columbia, if they're self-refer, we want them to be attached to a healthcare practitioner, like a family doctor or nurse practitioner. The reason is if we have a CT scan for the lung, in addition to things that are suspicious for lung cancer, there are what we call incidental findings that can be found on the CT scan. So example is we may see the severe coronary artery calcification, which is a reflection of the coronary heart disease risk that we can refer to the family doctor to optimize their cardiovascular risk management. So other things we can see is things like emphysema, lung fibrosis, sometimes a nodule in the thyroid, a nodule in the adrenal or the kidney, that kind of thing. So we do need someone to follow up those incidental findings. One important thing is smoking cessation. Dr. Patel pointed out in terms of prevention. In the general population, in the age group that we are talking about, like age 55 to 74, maybe only about 15% of people are still smoking in the general population. But the screening program actually attracts current smokers into the program. So about 40 to 50% of people taking part in screening are still smoking. So give us an opportunity to help them to give another attempt to stop smoking again. We can ask a very simple question, like how soon after you wake up in the morning that you smoke your first cigarette. The ones who smoke within 15 minutes, they're heavily dependent on the nicotine. So those are the ones that would benefit to see the family doctor to add pharmacotherapy in addition to the usual smoking cessation counseling to enhance their success rate. So you can see the family doctor have so many ways to play a very important role in terms of the lung cancer screening program.
And so I guess this will also be directed to you, Dr. Lam, because as Dr. Patel mentioned, unfortunately, there isn't a screening program currently in Alberta. So in BC, what is the process for a patient getting accepted into a program?
So currently, we're in the planning phase to set up the program to operate as of spring of 2022. So we have ongoing working groups with family physicians and other stakeholders, so to speak, to design the best way to recruit, to refer patients. But we will have a central calling center where people can call or fax the referral to the calling center. The main reason we don't want to take up a significant proportion of the family physician's time to go through all the risk prediction model questions. So we just simply ask the family physician if they see a patient in the right age group, 55 to 74, if they smoke 20 years or more, they're potentially eligible for screening. And then they can refer the patient to the central calling center, and the navigator in the calling center will administer the short questionnaire that takes about 5 minutes to do. If they satisfy the risk threshold, then they will automatically be scheduled for a low-dose CT scan, say within a couple of weeks.
In terms of how long it takes patients to kind of get seen, do you have an idea?
So we're going to have several health authorities as part of the screening program, very similar to what we're doing now with mammography. So there's screening sites that who have met the screening criteria, the screening site criteria in terms of the CT scanner and personnel training and radiologist reading certification and so on. So once that all is set up, they will be able to handle the patients who within the health authority for the screening program. So I think we should be able to handle the volume of patients that we projected, because the scan takes so short a time to do. Literally, it takes more time to show up to the receptionist to report than to actually lie down to get a CT scan.
And so what resources are available right now to GPs to increase in awareness and education around the screening program?
So in BC, the Family Practice Oncology Network just released a primary care lung cancer care guideline that is endorsed by the Medical Services Commission. So alluded to the lung cancer screening program. But once the details of the program has been finalized in the fall, they would update the web statement of the lung cancer care in British Columbia. Also in the PC cancer screening website, we will provide educational material as well as other information for the family practitioners as well.
And I would say from an Alberta perspective, as a family physician working within primary care, what we would want to know is exactly that information there. Is what is the benefit, but the harm, and also some sort of information where we can easily relay this to our patients, because we may not necessarily be physically doing the screening, but to get them to go for the screening, this is probably the value of primary care. We can help people understand and weigh up some of that medical information. Screening, especially screening for lung cancer, in that right group definitely has a strong evidence base. In the wrong group, it may do more harm than good. So again, that's trying to help influence and also dispel some of the false things out there. Within Alberta, we have our own validated websites which we use. So Screening for Life is an Alberta website which just has all of the currently endorsed screening programs, such as breast, colon, cervical. So then if and when Alberta follow on, it would probably be added to that, depending on how they choose. I really like the way that Dr. Lam's program is working, because the issue in primary care is time with the patient. We want to make the most value there. So getting our patients into the system through a nurse navigator or navigator is an excellent way of doing that. But then using the family physician to maybe use their knowledge as to what is the good and bad with this is probably a useful way. Again, some of the things that we'd be looking at here, if this is incorporated to that, of course, we've heard about age and smoking as the biggest things, but people are asking more and more about radon exposure within the ground, whether that's a factor that can be incorporated in. People are asking about travel exposure, multiple flights, and that increases radiation exposure. People are asking about general health conditions, diabetes and other conditions, whether that increases associated risks of cancer. And so I guess there will be hopefully these validated tools that have some of this. But one thing that isn't always well incorporated to tools is the primary care physician's gut feeling. And actually, that does come some way when it comes to cancer screening. Sometimes everything may fit low on a screening criteria, but there is something that may just make that family physician think differently for that patient. So that's something that sometimes comes into some of these algorithms.
In British Columbia, we have done a study looking at the effect of outdoor air pollution. So exposure to PM 2.5 is a significant risk factor, especially for people who have never smoked or only smoked very light in the past. So I think something we need to look into more, because as the population grows, increase in traffic and industries and so on, the PM 2.5 exposure is going to be higher. Another thing is because of immigration, people come with their past exposure when they come to Canada. So depending on what country they lived in before, their past air pollution exposure can be substantially higher than what we encounter in Canada.
So that's stuff that's not necessarily in the kind of risk model now, but it might be things that are being researched more and could potentially in the future be incorporated as well.
Yeah, that's right. It's something that we're working on to look at the effect of outdoor air pollution. Indoor air pollution like radon is a bit difficult to measure because we don't have long-term data as to how long people exposed to radon. If you have a meter to measure today, only tell you short-term exposure. It doesn't tell you what you have been exposed to in the last whatever decades, right? So this is one problem with radon exposure.
And I think that's probably where primary care can assist with education. We may not have to wait till they get sick with some of these. Helping people understand that these are some of the harms which are outside of smoking and age may help reduce the numbers overall as well.
By using these screening methods, what % of patients do you hope to identify earlier in progression of lung cancer?
So we hope to identify more than 70% of patients with what we call stage 1, 2 early lung cancer.
So what tests are performed during screening?
So screening only involves a simple low-dose CT scan. So a low-dose CT scan has only about 20% or less of the radiation with a diagnostic medical imaging scan. So it's equivalent to about 6 months of outdoor exposure to outside the radiation. So the radiation is there, but it's actually a very small amount. So we think within the screening context, the risk of a low-dose CT scan will be very small.
What kind of economic impact do you see of a screening program being implemented?
So using the risk model approach of screening, we have shown that lung cancer screening is highly cost effective. People talk about incremental cost effective ratio of it's really about $15,000 to $20,000 per life year gain. So I think it's very cost effective. Now, if we take into account the rising cost of some of the newer therapy, screening can actually be cost neutral or even cost saving. So it depends on how we use some of these agents.
So where do you see the future of lung cancer screening ideally?
So I hope every province and territory in Canada would implement lung cancer screening to reduce the mortality of lung cancer.
Yeah, I also see the future of lung cancer screening probably embedded eventually within the patient's medical home, which is really within their primary care network. But I really think that will probably be by having our computers assisting us with this process. So patients' data, age, smoking history, recorded in a searchable format that actively pushes out our patients to us, telling us this is a patient who flags up, go and talk to them. And then I also see other tools helping us as we refine that process. Biomarkers, better diagnostic imaging as we move forward can add value to this process and accuracy as well.
So I wanted to ask one last question before we end our discussion, and that is, what is your key takeaway for GPs in Western Canada regarding identifying, referring their patients for lung cancer screening?
So my takeaway message is lung cancer screening saves lives. The additional benefit to lung screening, such as using incidental findings on the CT scan to decrease other major disease risk or mortality or morbidity, such as cardiovascular disease, and optimize the treatment of COPD. And using kind of what we call the artificial intelligence in the future, we can actually use a CT scan to look at bones for osteoporosis, for example, and other things as well. So I can see it's an integrative healthcare approach, not just for lung cancer screening, but for reducing the risk of other major diseases such as cardiovascular disease or COPD. But integration of smoking cessation is also very important.
And I would say probably from my perspective, for GPs in Western Canada, the data and the evidence definitely supports lung cancer screening in the right population. I would also say maybe a second thing for primary care is not to be overly reliant on using chest X-ray for screening, because again, that doesn't seem to have the same type of level of data supporting that. And then again, finally, a third piece for primary care is that cessation, smoking cessation in particular, is probably still a more proven and powerful measure. I would just say, I'm keen, and I hope Alberta can move forward with that. At the moment, from what I can see, the Canadian Task Force's recommendation is due to screening-related harms, this screening should only be done in centers with expertise for early detection and treatment, which sounds great in paper, but really that means that creates a barrier to accessing screening.
Okay, thank you both so much for a very informative episode on lung cancer screening. Take care.